Greetings, everyone, and welcome to this webinar provided by Doctor's Data. Today, we will be discussing the ability of the GI 360 stool test to bridge the gaps in functional assessment of gastrointestinal health. Myself, David Quigg, I will be presenting a detailed overview of the methodologies incorporated and how to walk through the test results. And my colleague, Dr. Julia Malkowski, will then present some very interesting case reports. So in a nutshell, the GI 360 stool test incorporates complementary methodologies inclusive of PCR analysis, parasitology, culture, stool chemistries, and direct susceptibility testing. Now, it's very important to appreciate that when you're trying to characterize the intestinal microbiota, there is no single perfect method to meet all of your clinical needs and inquiries. And so we combined a series of methodologies to accomplish that end. So we use culture. It is still the gold standard for microbiology. Culture identifies by the proteomic method, MALDI-TOF, pure isolated organisms. And at Doctor's Data, we can identify over 1,400 bacteria and fungi at the level of genera and species. Now, what's really cool about culture is it extends your analysis to identify unique organisms, such as Archobacter species and atypical fungus and yeast. Now, the isolated organisms by culture are absolutely required for standardized antimicrobial susceptibility testing. No, so that's great. Culture has its place, but it also has severe limitation, and that is most bacteria are not routinely cultured, and especially the fastidious obligate anaerobes. So to complement the culture, we use PCR. Now, PCR-based testing looks for specific nucleotide sequences that are associated with unique bacteria, parasites, and even viruses. And at Doctor's Data, we only use PCR platforms that are approved and cleared by the FDA and the European Union. That European Union designation is CE marked. Now, using these such highly validated platforms is the key to reliability, because standardization within these platforms leads to very high sensitivity, specificity, and most importantly, clinically, reproducibility from patient to patient, test to test. Now, PCR is the standard of care for pathogenic bacteria, viruses, and parasites in the hospital setting. And it's a great tool, but it has limitations. And the primary limitation is that the results that you get are limited to the specific primer sets that you have in hand. So it asks, is it there, as opposed to what is there? Now, having said that, there have been extensively expanded primer sets. And one such example has been used in a very novel approach to looking at the gastrointestinal microbiota. So this novel approach uses a very large set of PCR probes, and it is specifically a dysbiosis test. So it is a targeted microbiome DNA analysis tool to identify and characterize dysbiosis. Its heavily research-based set of predetermined PCR probes targets the most clinically relevant bacteria, that is, with respect to specific condition or disease endpoint. So these 54 probes for bacteria cover the 6 primary predominant phyla, 10 classes, 36 genera, and 356 species. This highly published method incorporates a well-defined normal biotic reference population currently at greater than 500 and growing as I speak. So this is CE marked, approved in the European Union, and it is highly, highly reproducible. And to look in much greater detail into that reproducibility and the characteristics of the PCR platform, I encourage you to view the webinar by Dr. Joel Mortensen at the gi360.com website. Now, also included in this model is a dysbiosis index, which is a mathematically derived score that indicates the deviation from normal biosis for the patient's test results. And that dysbiosis score goes from 1 to 5, with 5 being the most severe. Now, in the early validation, clinical validation studies for EU approval, the Norwegian investigators compared the dysbiosis indexes for healthy subjects, IBS, and IBD patients. The healthy subjects were extensively defined by a very, very large questionnaire. IBS was defined by Rome 3 criteria, and IBD was confirmed by scoping and or biopsy. Now, a dysbiosis score greater than 2 indicates significant deviation from normal biosis. So let's look at the results. If we look at the percentage of the different cohorts that were dysbiotic by the dysbiosis index score, we can see that across the various groups of IBS and IBD, there was about greater than 70% of the cohorts were classified as dysbiotic. Now, if we look more carefully at that data, we can see that as we go from healthy to IBS to IBD, there is an increased percentage of subjects within the IBS and the disease categories that had scores not only greater than 3, but even into 4 and 5, as we see predominantly with the IBD. Okay, so many subjects with IBD with scores, and that's even in remission, okay? So this test, this platform, this whole concept has been published in over 25 papers to date. That includes 50 studies and over 5,000 patients. And some of those cohorts included obese versus non-obese, looking at the effects of an extreme low FODMAPs diet on the microbiome using this model, looking at the microbiota changes during the progression of ulcerative colitis in children. And my favorite is the study where they follow the kinetics of the microbiota. That is the time course for change after fecal microbiota transplant or fecal transplant. So let's look at the first page of the report and walk through how to interpret this report. First thing we look at is the patient's microbiome bacterial abundance and diversity summary. And that summary is indicated on the inside of this hexagonal diagram that shows the 6 primary phyla. So the targets within each of these primary phylas. The patient's profile is indicated by this white web on the inside here. So as the patient's profile deviates more, it will pull away from this ideal, what I call the sweet spot, which would be this green zone, which would be 0 deviations from normal biosis. As we go further away, we get out to approaching 3 standard deviations away from normal dysbiosis, normal biosis for the particular phyla. And as we pull to the center, we see a marked decrease in abundance. So you want to be out in this, this what I call the sweet spot. So from the full set of data, the dysbiosis index is calculated. And here we can see a dysbiosis index of 4, which is a club that neither any of you nor your patients would really want to be in. And I can't emphasize enough that this dysbiosis index pertains to specifically to the bacterial assessment using the specific PCR-based model. This dysbiosis index does not include the influence of dysbiotic bacteria, yeast, parasites, or even viruses that we find in subsequent panels of the test, okay? So just from this PCR model. Now, of course, on the first page, we summarize the key findings within the set of PCR probes for dysbiosis. And then over here also is where we would report nasty things like salmonella, parasites by parasitology, and PCR, and also things like very low or very high secretory IgA. Now, if we want to take a closer look at what constituted this deviation from normal biosis, we could look at the full panel here. And what I like to do with this is I really like to look personally, with my bias towards looking at the contribution of butyrate and the mucus barrier to gastrointestinal health. I like to look at the key butyrate producing bacteria and do that in the context to the balance with those primary bacteria that break down the mucus, those mucolytic specialists. So while Akkermansia mucinifera is a superhero with respect to being anti-inflammatory, if we have excess abundance of Akkermansia colonization, we can actually start to break down that crucial mucus barrier via the mucolytic capacity. Then, to really understand how to interpret those results, we have to realize that we're looking at the results reported as standard deviations away from normal biosis. So 2, 3 standard deviations low, 2, 3 standard deviations high. And we can see that in this case, for something like the Allostipes onderdonkey, you can see that it's 2 standard deviations low. So this is not to be confused with the 1 to 4 plus, or the +1 to +4 that we see in culture where we're looking at colony forming units. This is standard deviations away from normal biosis. Now, we also use a different PCR platform to specifically address the gastrointestinal pathogens, the viruses, the bacteria, and the parasites. And to complement, again, the fact that we have a limited number of parasites by PCR, we use O&P, where we can identify the presence of another 30 parasites. Now, while we're looking microscopically, we also look for significant clinical findings like an overabundance of yeast that may or may not have cultured. And also very important to clinicians is the consistency of the stool on the day of that collection. That really helps with the interpretation of the overall report. So for microbiology, we report for every patient the classic 8 truly pathogenic bacteria. But the beauty of culture is that we can also go beyond and look at the imbalanced bacteria and dysbiotic bacteria for which there are no highly standardized PCR probes. So a real advantage of adding culture. And then, of course, we look at yeast by culture. In this case, no yeast were cultivated. Now, it's very important to realize that all of these panels are expandable, even the pathogenic panel, because unique to doctors' data, by using our culture conditions and the Moldy-Toff method, we can uniquely report Laribacter hongkongensis and Archobacter butzleri, which are true pathogens. Now, these fields are all dynamic and expandable. So if Laribacter and Archobacter are found, they would be reported here. But all of these fields are expandable. So every test report is not going to show the same list of culprits. And to emphasize that, I draw your attention to another report here for a patient where we see an extensive listing of the imbalanced bacteria, none of which had moved into the dysbiotic category. So there's really no dysbiotic bacteria here, but this field expanded greatly, as did the field for yeast. Remember, the last patient had no yeast, said no yeast. Here, we expand the panel, and importantly, that panel of yeast can grow to as many as 180 different species of yeast, because that's how many we can identify with Moldy-Toff. You're never going to see that, thank goodness. So, to emphasize again, these are expandable panels, and no two test reports are going to list all of the same analytes. And you can't have a truly comprehensive stool analysis without these important stool chemistries, the digestion and absorption markers, the inflammatory markers, both the lactoferrin and calprotectin specific for IBD, and then the distinction between IBD and non-organic inflammatory bowel disease inflation, as indicated by lysozyme, which is commonly elevated with enteropathogens. And of course, secretory IgA being the brick in the mucus barrier. In this case, on the low end, y'all know what to do there. And then the short-chain fatty acids, the relative distribution that's really showing the overall balance of the microbiome with respect to the metabolites, the key metabolites, the short-chain fatty acids, but most importantly to clinicians, the absolute and total concentrations of butyrate and short-chain fatty acids, which here are quite low, dismal, and too commonly seen with a SAD diet, and most often associated with terribly insufficient consumption of soluble fiber. And of course, we also look at other health markers, including beta-glucuronidase activity, which of course breaks down that tight bond between toxins that have been glucuronidated, and the body has worked so hard to kick out into the bile. Now, I can't emphasize enough the need to have pure isolates by culture in order to do true, authentic susceptibility testing. It absolutely requires a pure, isolated organism expressing its phenotypic characteristics. So for every patient's dysbiotic bacteria or pathogenic bacteria and yeast, we will do susceptibility testing with a host of natural agents, botanicals, as well as prescriptive agents. There's no wall charts used. Okay. So in a nutshell, the GI 360 provides a full complement of methodologies that provide an extremely comprehensive view of gastrointestinal microbiota, microbes, and gastrointestinal health. So I turn it over now to my colleague, Dr. Julia Malkowski, who's going to present some interesting case reports. Take her away, Julia.
Thank you, Dr. Quigg, for that excellent overview. Today, we will be discussing intriguing GI 360 cases to provide insight with regards to clinical practice. Case number 1. This is a previously overweight individual. This individual has been struggling with obesity and depression actually for lifelong. They are in the care of a psychiatrist at this time, and that psychiatrist decided to do the stool testing. Within the last 3 months, the patient has switched to a less processed diet and they have lost 20 pounds. They have been treated with 3 rounds of antibiotics for H. pylori recently. We see here with the microbiome abundance and diversity. So the web is a visual representation of abundance and diversity. A perfect result would be a hexagon right there, right at that gray line within the green, a perfect hexagonal shape. We can see the patient has a good amount of abundance because that white shape is a good amount of space, surface area. But the diversity is incorrect in that we're lower in the actinobacteria, lower in the tourniquetes, pulled toward those proteobacteria, lower in the firmicutes, and then pulled toward the bacteroides. The proteobacteria actually are associated with inflammation, and that could be contributing to the patient's dysbiosis index score of 5. So recall that dysbiosis index scores above 3 are associated with deviations from normobiosis and do have a high confidence interval to associate with dysbiosis with regards to IBS, IBD, obesity, low FODMAP diet. So we'll learn a little bit more about what's making up this patient's dysbiosis index score. So we see here the first column is the key findings, and those key findings have been calculated to create the dysbiosis index score. We see here the patient is higher in the dialster vistus and the megasphaera micronuformis. The dialster vistus is more of a endodontic pathogen associated with spondyloarthropathy. This patient does not have that diagnosis, although I have seen other cases where there is that correlation. The parabacteroides are high for this patient, and those are associated with obesity, increased body weight, and the eubacterium is very low for this patient, and the Faecalibacterium prausnitzii is very low. That's important because the Faecalibacterium prausnitzii is a key butyrate producer, and when the patient is low in butyrate, that is going to potentially predispose the colon to inflammation. The patient's also low in actinobacteria, all stripes, higher in the proteobacteria, again, which are associated with inflammation, lower in the all stripes Andernacki, higher in the Bacteroides fragilis, and higher in the Escherichia species. Something to note here is that the low Faecalibacterium prausnitzii is associated also with depression. And when someone is low in the Faecalibacterium prausnitzii and high in the Escherichia, that specifically is associated with untreated IBD. So this patient, although does not have the diagnosis of IBD, we see that the bacterial makeup is trending that way. There's a dysbiosis index score of 5, so this is potentially predictive information. Proteobacteria increased and Escherichia species increased are associated with the standard American diet. So this might be a patient to really highly recommend a dietary intervention. When the Faecalibacterium prausnitzii are low, as they are in this case, we do recommend inulin that has been proven to increase that key butyrate producing species. Secondarily, we see the second column here talks about the other findings within the GI 360. So the patient does have a fat stain that is likely dietary related. We do see higher propionate, lower valerate, so we do see some short chain fatty acid imbalance, and that does make sense based on the dysbiosis of the microbiome. And we do have a high fecal secretory IgA. Potentially that's associated with a gastrointestinal infection in the past 4 to 6 weeks or a food sensitivity. Now we'll move on to the second case. The second case here we see, this is a patient that presented with ongoing joint pains, does have a history of hypothyroid, chronic constipation, and diarrhea, which has considerably worsened since a trip to Hong Kong in 2019, so a few months before this test was done. The patient is currently on quite a few pain medications due to a bike accident in the summer of 2019. So here we see this patient's microbiome abundance and diversity. This is, we can see here that web is almost making that hexagonal shape, but it's actually a little bit pulled in with regards to all corners there. So abundance is low and diversity is off too, in that it's skewed toward the proteobacteria. Recall those species are associated with inflammation. And here we see a dysbiosis index score of 5. So more information here that there is inflammation in the patient's colon and potentially causing that history of constipation and diarrhea. Now, within the key findings, we see that the patient has high proteobacteria associated with IBS and IBD, low Clostridia, so potentially low butyrate, very high Streptococcus species, high bacilli, decreased Eubacterium cereum, low lacnosporaceae, so that is a low butyrate producer. And then the Streptococcus is higher and the Veillonella is lower. Now, secondarily for this patient, so we do have a dysbiosis makeup with the microbiome, but we do see some enteropathogens. We have the Salmonella species, the Giardia, then we have cultured Citrobacter, cultured Klebsiella, cultured Geotrichum yeast species, very high lactoferrin, and then high fecal secretory IgA. In this case, the high fecal secretory IgA is actually appropriate response to the enteropathogens. The second page we see here for this case is the GI pathogen profile. So this is the PCR technology looking for the DNA. And we do see the patient is positive for Salmonella and Giardia, and that could very well be causing the chief complaints. Secondarily, we do see the culture omics for the bacteria, and we have cultured the Citrobacter and the Klebsiella. That's very great because, as you'll see in a minute here, we have provided the susceptibilities to these cultured bacteria and the yeast as well. So here we have the two cultured dysbiotic bacteria, the Citrobacter and the Klebsiella. So the Citrobacter and the Klebsiella are showing high sensitivity to grapefruit seed extract, silver, and uva ursi. Really, those are the top 3. So we'd recommend using 2 for 4 to 6 weeks. And so this would be a test where you'd want to recheck. Recall the lactoferrin was elevated, so you do want to recheck that in 4 to 6 weeks. If it did decrease, then it was elevated to the enteropathogens. You'd expect these dysbiotic bacteria to be cleared up too with the treatment. And then if the lactoferrin has not decreased, you might want to consider IBD for this patient, especially considering that dysbiosis index score of 5. Okay. Here we have our third case. This patient is on a ketogenic diet, and this patient was doing that potentially to treat their diagnosis of diabetes, type 2 diabetes. Now, we see ketogenic diets quite often now in popular culture, so it's interesting to get a look into the colon of this popular diet. Here we see the microbiome abundance and diversity. Here, this patient is really skewed toward those vermimicroba and lower in the actinobacteria, lower in the Firmicutes, lower in the Turnicides. So the abundance is okay in that there's a good amount of white space surface area, but the diversity isn't not balanced. And we can see they do have a dysbiosis index score of 5. The species here that we see very high Akkermansia. Now that is key because the Akkermansia is important to the mucosal barrier. When it's too high like this, it's actually eating the mucosal barrier of the colon and leaving the patient at risk of decreased mucosal barrier and then inflammatory reactions, increased intestinal permeability, and cascade of events. So this is very important actually. We also see the Fusilibacterium protenitzii is very low, and again, that is a key butyrate producer. So again, the patient is going to be at risk for increased inflammation in the colon due to the low butyrate. Low total short-chain fatty acids, that's going to be typical. Lower actino, lower bacilli, lower lactose brachiae, again, a secondary butyrate producer, and then the low Vianella species. The patient also has candida, so yeast. We see a higher pH, and that's really sometimes associated with standard American diet or a constipation type of stool. We have a higher percent propionate, so that short-chain fatty acid imbalance due to the dysbiosis index, the dysbiotic microbiome. We have lower butyrate, again, that goes back again to the lower beneficial bacteria, and lower total short-chain fatty acids and low fecal secretory IgA. So to address this here, we'd really want to see the patient increasing their soluble fiber, 5 to 10 grams per day, and then especially inulin is indicated for that Faecalibacterium protensi species. Okay. So here we see the stool chemistries of this patient. And looking further, we can really see the patient has low butyrate and low total short-chain fatty acids. Now, that is going to potentially leave the patient at risk of inflammation and cascade of inflammatory events within the colon. Now, we did see that this patient is on a ketogenic diet, and potentially these two things are related, so this is something to consider with the FAD ketogenic diet. Speaking of FAD diets, we have our fourth case here, and this patient has presented with GI distress. This patient is on a self-prescribed carnivore diet to avoid self-proclaimed plant reactions. The carnivore diet is becoming more and more popular in culture, and it's good to see what that looks like within the human microbiome. Here we see the abundance and diversity summary, and the patient really is having a small decrease, I would say, in that abundance with the white surface area skewed toward the bacteroides. And really within that bacteroides, we see a higher bacteroides stereococcus, and that is a virulent bacteroides and potentially associated with complications, and we have seen it in some infections. So that's the bacteroides group here. But we do see that the patient is on the the carnivore diet, and within the carnivore diet, they do have a dysbiosis index score of 4, so a dysbiotic colon. And here we see the specific group, again, the Bacteroides stereococcus, and that is higher in this patient. It's a virulent bacteria, potentially drug resistant, so that's one you do not want in your colon. And adding soluble fiber, 5 to 10 grams, and potentially decreasing these undesirable bacteroides group would help this patient. Now, here we see for this ketogenic, the carnivore diet patient, we do see that this patient is a little bit lower in butyrate, and they're also lower in total short-chain fatty acids. So those are definitely low, and they are low within elastase. And we do see a positive occult blood here from the carnivore diet. So I'm wondering if that is due to the meat from the carnivore diet, or if there is other pathology going on here. So you want to retest in 4 weeks. But we do see quite clearly here that a patient on a carnivore diet is lower in butyrate, total short-chain fatty acids, positive for occult blood. The pH is even getting up there. So is this the best diet for human health? You know, at this point, it would be prudent to actually potentially recommend a dietary intervention for the patient, increasing soluble fiber. And that is it for today. Thank you very much for your attention. If you have any questions, please visit www.gi360.com. Thank you and have a great day.